So, hello, everyone. Hello, hello, hello. Good evening, good afternoon, wherever you are. Hello, everyone. My name is Bob Miglani. Welcome to the live stream event. Dr. Ryan Beck, how are you? Hi.
Hi, thank you so much for having me here today, Bob. It's great to be here hanging out with you tonight.
Delighted to see you this evening, Dr. Beck. So, we've got a lot of wonderful things in store for you today, folks. So, this webinar is about how to market your LipiFlow. LipiFlow, if you don't know, is a mainstay in the armamentarium of armamentarium toolbox. Okay, I can't pronounce that word, Dr. Beck. Armamentarium. Okay, toolbox for optometrists, for eye care professionals who practice dry eye disease management. And Dr. Beck is an expert. So we're going to first get started by learning a little bit about Dr. Beck. Before we get started, though, I just want to let everyone know this is being streamed live. You can catch us on Instagram, on LinkedIn, on the Dry Eye Doctors Facebook group, our YouTube channel, and right here on StreamYard. Whatever questions you have, please feel free to drop them in the comments, text me, let me know, or message me on Facebook. Let me know what questions you have. I'm happy to be the moderator to ask our expert here today, Dr. Ryan Beck, talk to you about it and answer any of your questions for you. Okay. And if we don't get to your questions, please text me, email me, or private message me, and I'm sure we can get a hold of Dr. Beck to maybe answer some of those questions. He's an authority on dry eye disease, and I want to get the best resource for you, for us, for here. All right. So why are we doing this? Who is Bob? Just to introduce myself. My name is Bob. I founded Hoot with my spouse. Her name is Dr. Shefali Miglani. She's an optometrist, private practice in New Jersey. I worked at Pfizer for about 20 some odd years in sales, marketing, and other things. And I helped my spouse in her journey of converting more patients whose children have myopia into myopia treatment. That led us down this path of creating Hoot, which is a marketing automation system. And then as we got into this journey, we realized more and more doctors said to us, Bob, we've got a problem with dry eye disease. How do we educate these patients so that we get them enrolled into a dry eye treatment program, such as a LipiFlow or an IPL or others? And so we launched Hoot Dry Eyes last year. There's about 140 clinics across the country that utilize Hoot for myopia or dry eyes. And so what we do is we put together great programs like this for you, bringing great speakers and guests like Dr. Beck here to educate all of us, okay? We're not here to promote our Hoot brand and our product here on this live stream. If you want to learn about it, go to gethoot.com. What we do want to do is give you massive value, okay? So we hold webinars almost once a week. Check us out on gethoot.com/events. And these events are really for you to learn, to get educated, and to put things into action. All right. So let's act now. Let's talk enough about me. Let's talk about you. So Dr. Beck, please tell us a little bit about yourself, your journey, who you are, where you practice. Tell us a little bit about you, please.
Sure. So my name is Dr. Ryan Beck. Obviously, it says on that little ticker down on the bottom. I am the medical director for a group called Eye Care Advisors. And our group, we have 9 practice locations. 8 locations are primary care opticals that do comprehensive, eye care all the way from, primary glasses and contact lens refraction, all the way up through glaucoma care, et cetera. And then the practice that I specifically practice in is a dry eye referral clinic. So I actually got started with dry eye passionately back in about 2017, 2018, when the DEWS 2 report came out. And I was the specialty contact lens fitter in the practice. So there was a lot of cohesion that went there. And when I found out about all these wonderful technologies like LipiFlow that were available to me, I said, I want to implement that in my practice. And how can I be able to make this happen? So for about 2 years in our primary practice location, we built that up, and it became so prominent that the demand was so high, we had to pull it out and make its own dry eye referral clinic. And what my goal is now is to share, the good and the bad that happened through that process and learning, and how we can help other practitioners make that transition happen even quicker and really enhance their practice capabilities with their patient base.
Amazing. Wow. What depth of knowledge and experience that you have, Dr. Beck. So tell me, just, step back for a second. You saw these patients coming in and they had dry eye disease. And give us a sense of the potential for the audience here. So if they have a practice, give us a sense of how many patients, like what's the number? I don't see, there's not a lot of data. Some say 20%, some say 40, 50%. What number of patients coming in for comprehensive visits a month do you think have dry eye disease truly?
That was the thing that was actually pretty surprising to me when we first got started with this, and we were referencing the Lynn study, like what's a good dry eye lecture without looking at the Lynn study and saying 86% of people who have dry eye have a meibomian gland component, right? But when you look at the data, and one that I reference a lot is from Dry Eye Directory, and this is a nonprofit, website organization, is that the estimates show anywhere between 18 and 50 million people in the U.S. are suffering from some sort of dry eye disease at this point. And for those of you unfamiliar, we're looking at that's a little over 10% of the population that is suffering from the same diagnosis at this point.
Wow. Wow.
And that was a pretty generous estimate. So obviously we felt that it was coming in, and sure, we see things in the chair during my regular comprehensive exams. We'd see standard things like decreased tear breakup time or fluorescein staining patterns that were indicative of dry eye. But what was really interesting was when we started to look. And what I mean by that is when we started doing things like meibography imaging or actually evaluating the meibum that was expressing on these patients, it seemed to be a lot more than 10%. It was almost every patient who came in the door had some sort of dysfunction that was going on with their lids or meibomian gland dysfunction. And I don't think my practice is all that unique, that we just have the mecca of dry eye patients that's there. I think that naturally, that's the way that the trends have been going with remote work, with diet, with medication, with all these different aspects. We're starting to see some more dry eye start to come about, and it's important for us. And I'm actually going to use your term from before, armamentarium, to have that present, because I look at us as eye doctors as being on the front lines. We as primary care optometrists have to be the ones first and ready to fight the battle that is dry eye that's coming, and it's actually in our chair right now.
Yeah, and it's not even just adults. One thing, so just give you an example, it's kids, right? So we had we have 3 kids, 19-year-old is the oldest. She was in college. She comes home, and she's visiting. A friend of hers is visiting us from California. They went to New York City, and we were sitting at dinner at home in New Jersey, and my wife is an optometrist. So this young girl says to my wife, "Auntie, can I ask you a question?" And she goes, "Sure. I know you're an eye doctor." She goes, "I have meibomian gland dysfunction." I was like, "What?" She just said 19. And she goes, "I have no lower glands. I have no glands left on my lower lids."
Mm-hmm.
And my wife and I were like, "Holy cow, like what just happened?" And my wife says to her, "Hey, by the way, are you a reader? Do you read a lot?" So she goes, "Yes, I've been reading since I was 5. Oh, and by the way, I have myopia. I'm an ortho K as well." And so the question was, well, how did you get diagnosed? Well, some doctor did a scan and did the meibography. And so thank God. And then now I do blinking exercise, all that. But my point is that it's not just adults, Dr. Beck, right? It's these kids who are just on these screens all the time. And of course they get myopia of some kind potentially, but dry eye disease. So do you see that as well with younger population?
We do, and we actually started picking that up when we started imaging. We went for low-hanging fruit first. We went for every contact lens exam that came into the practice, and we started doing a lower lid meibography, just as included in the contact lens evaluation. And when we were starting to do that, we noticed that kids as young as 7, 8 years old, sometimes even younger, were actually presenting with some sort of meibomian gland dysfunction. Obviously, some of them had, external factors that were part of it. Some were internal factors that were part of it, but it was still there, which was truly surprising for us. And because of that, it's made us make a shift in our treatment modality to start, implementing those in-office treatments a little bit earlier than we may have not, considered in the past, because we're more on the lines of preventative medicine, right? Because we know as practitioners that once a tissue is dead, it's gone. I mean, most of us are pretty good, but I still haven't met one that can raise the dead yet. And so what we're looking to do is be able to preserve what we have and make it as functional as possible.
Yeah, that's absolutely right. So let's talk about, I really want to tap your expertise on 3 things, Dr. Beck, tonight. The first is, let's talk about the patient and what are the what's your treatment, protocol and guidelines on that. Talk to us about that. And then, or how they present and how you communicate with them. Right? How do you actually explain to them they've got MGD or dry eye disease, and how do you talk to them about it? Second, I'd love to get your tips for the doctors here, optometrists here, ophthalmologists here on the call, and educate them a little bit on tips on how to engage patients, How do you get them to, follow your recommendations, your prescriptions? And then third, let's talk about LipiFlow. I really want to get into LipiFlow, but I want to start with the patient first. So let's talk about the patients. You diagnosed, it sounds like you're diagnosing based on a clinical finding, which is the mybography. Hey, this is a scan of your eyelids, lower lids. So talk to us a little bit about the journey of the patient and then how you communicate the disease and the treatment for that patient, please.
Sure. So when it comes to diagnosing, there's two main areas for diagnosing meibomian gland dysfunction from the diagnostic side that I count on, as well as we obviously rely on the patient history and their symptoms that go into it. So starting with the symptom side of it, there's lots of different symptoms that go along with dry eye. We hear everything from irritation, pain, burning, tiredness at the end of the day. But interestingly enough, what we've been finding from our research is that the most prevalent sign is fluctuating vision, which kind of makes sense, right? As the tears start to disappear, we lose that tear film layer, the tears evaporate. It's like having a hole in a contact lens that you're trying to be able to see through the clear part that actually has the prescription in it and the hole that's gone. It's really just not going to be the most effective in clear vision for us. So that's one of the first key pickups for us, that we need to start doing our imaging in the first place. The second thing that we also look at is that mybography. That infrared mybography is truly a gauge of structure. Right. And so we think about meibomian gland dysfunction, which is different than structure. At least what it is, it's a snapshot in time to tell us, okay, something bad has happened in a process here. It's altered the structure of the gland. And if the structure of the gland isn't the best, then it's probably dysfunctional. Okay. Then the third part of it, too, is testing the function. And parting the testing the function, we actually use another device from Johnson & Johnson called the MGE. It's the Meibomian Gland Evaluator. And if you've never seen it before, it's a really fancy piece of plastic that is actually, it's calibrated with 0.3 PSI into the plastic itself and presses on 5 meibomian glands at a time. Reason why that's important is that 0.3 PSI simulates the standard pressure you would get in a blink. And when you place that up against a lid margin and test 5 glands at a time, you can see with standard blink, are they actually expressing meibum? Are we getting some function in there? And so between what the structure looks like and what the function looks like, if we don't have enough glands that are producing meibum, we know we have a problem. And then it's time to start implementing protocol to be able to relieve that issue.
Got it. No, that's so. You do this, like, tell us the stages of when you do this. Is it sort of comprehensive? You have them come back. Give us a sense of the flow, if you will.
Sure. So when I was doing the primary care, because now I'm in the referral clinic and I'm not doing this as much, but the way that I started it out was doing all of our pre-testing procedures, like our autorefractor, IOP, fundus photography, what have you, and including the lower lid mybography. That was just part of our standard evaluation. Yeah. And as we got through our imaging and had these conversations, we would start to say, look, I see that there's a problem with the structure here. And it's leading me to believe that there could be a problem with your function for dry eye. And I express concern. That's where it is to say, I'm not saying, oh my gosh, you absolutely have to get started on treatment right now, but I'm concerned by the way this progresses, that you're going to, if you don't have a problem now, have a problem in the future. So what I'd like to do is bring you back, because I've seen this clinical sign. Right. Let's talk about this in more detail, as well as do some more advanced testing. Right. So when we come back, not only are we doing the mybography, the imaging, that's when we start implementing more things, such as tear osmolarity, inflammatory MP9 testing, the vital dye staining, looking at blink analysis with the LipiFlow 2. We look at multiple different aspects that all kind of correlate it and give us a much bigger picture on what is truly affecting dry eye. And now that we've delved deeper than we could have time for in the comprehensive exam, it's generated a lot of faith in the patient to say, oh, wow, they actually do know what they're doing and talking about. So I should jump on the plan for these guys, because I think that I'm going to get relief, or at least prevent bad things from happening by following their treatment protocol.
Yeah, no, I love it. I love the process that you've aligned. And in fact, at Hoot, we call it the Hoot method, but it's based on 140 practices. And essentially it's exactly the same. It is that in the comprehensive, we don't cram the comp, and we don't talk treatment in the comp. Simply make the diagnosis based on the clinical findings and express concern. It's really important to do exactly what you said, which is just express, this is not normal, Mr. Jones, and let's get you back on track. But I need to dig deeper, and therefore I need to have you come back. Now, that coming back for the follow-up is absolutely critical. Now, I'm reading this phenomenal book, Dr. Beck. I don't know if you read this, but It's called Story Brand by Don Miller. And Don Miller says that, there's two key principles he talks about is one is, keep, it's in anything. Nobody cares about our product or our service. They care about their lives, right? They care about themselves. And so we must talk the problem a lot more. And one of the other things he says is that what we must do is talk 75% about the problem the patient has or the customer has or somebody we care about has, and then only 25% about the solution. Because that's human beings are selfish. They want to talk about their problem. And what that means is exactly that. Make the diagnosis. Don't try to push or a treatment or anything. Have them come back and promise to dig deeper. So absolutely right on. I think this is absolutely the gold standard process that you've outlined here. So now, talk to us how you talk to the patient in the ocular surface evaluation when they come back. You do the test. Okay, you do inflammatory. You're doing tear osmolarity, tear breakup. Once those tests are done, how do you communicate what treatment options you present to the patient?
Sure. So it's in a general aspect, especially at the referral clinic, many patients either have been told they might have some dryness with the eyes prior, or I might be the first person to tell them that what they're experiencing is dry eye. But I usually start with the question, if they have seen a doctor or not before, has anybody told you that there's different types of tears on the eye? And when they say, no, what do you mean there's different types of tears? Well, I make the analogy that there's hundreds of different proteins that are on your ocular surface at all times. And specifically, the tears are a film that settles into three distinct layers. We have our mucus, we have our water, and our oil. Mucus to bind the tears there, water to hydrate and oxygenate, oil to protect it all from disappearing. And our goal with all of our testing is to see which layer or layers are having a problem and what we can do to restore homeostasis to those layers. So that's I say that probably 20 times a day, which is why it came off so smooth. And so what we wanted to do was to give them a visual, right? They can visualize the layers. It's kind of like a lasagna in their minds to say, okay, we have to have everything stick together, and then everything will start functioning a little bit better that way. And so when it comes to the diagnoses, each different diagnosis or different layer obviously is going to have a different treatment that goes along with it. And primarily, we're going to see a lot of MGD come through, especially that 86% number. So there's a lot of time we're having that conversation. Now, going back to that CEDARS and DUCE 2 report kind of era of 2017, 2018, we got a lot of good information from these protocols. Some gave some guidance on what to do at what stages. But if you read the DUCE 2 report, and I'm not sure I've met anybody who's truly read every single page of the DUCE 2 because it's huge. I've read the executive summary a number of times. But the DUCE 2 report gives you all the information on these treatments, but always says, leave it up to the doctor at his best discretion of what to implement and when. But also part of that report says there are main target areas to focus on. And those main target areas are A, are the lid inflamed? If the lids are inflamed, then we've got to decrease the inflammation. B, are they physically obstructed? And if they're blocked up and obstructed, we have to remove that. The third is we need to increase production, right? We need to make sure we're making enough oil in the first place. Yes. So inflammation, obstruction, production. And so we've heard those initials before, IOP, obviously a different area of eye care, but I'd like to say IOP can also apply to dry eye, right? Inflammation, obstruction, production. And if you can think about that on the MGD side of things, well, then you can actually start to base your treatment plans on having something for an inflammatory process, something for an obstructive process, and something to make a little bit more too.
I love that. I love that. So the conversation then, okay, so then how do you move the patient to say, okay, let's talk about certain treatments. So let's, I don't know, what do you begin? One question I have is just back for a second. So talk about just in terms of deciding between those three. I love those three here between home care, doc, I don't have any symptoms. Why do I what's going on? Why do I not have symptoms? So this is another question Dr. Rebuck here asks is, what do you find is helpful in getting asymptomatic patients to return, right? If they don't have any symptoms, what are we going to do here? Explain that. So to answer that.
Sure. And when it comes to, well, I guess it's a kind of a two-part question, right? What do we do at home? And then how do we get the people without symptoms to dive in? So when it's without symptoms, that's where I believe imaging is key, because images talk 1,000 words, right? And then we only have so much time in the chair to be able to speak. So let the images do the talking for you. So in our office, we're really big on interior segment cameras. And for example, if you have a patient with diffuse scurfs and collarettes that is indicative of a Demodex blepharitis, office and you're starting to see the punctate staining, all throughout their cornea, but maybe they're neurotrophic and they don't feel it, what's going on, you can at least physically show them the signs that, you're not supposed to have crust building up on your eyelashes. Or you have this bright neon picture that has these firework kind of spots when it should look a deep forest green. Those are things that can say, okay, this isn't the way that it's supposed to be. Maybe I should have a listen on what's going on. And now when it comes to at-home treatments, obviously I'm trying to target those three main areas, the inflammation, obstruction, and production, but I'm also trying to be cognizant of the patient's routine at home. So I try to stay away from prescribing multiple of the same modality. Like I don't want to do one drop for hydration, one drop for oil, one drop for antihistamine, because they're not going to remember exactly which drops to do and when, or in most of the cases, patients are going to struggle with compliance a little bit. So I try to keep it under different modalities. For example, I'll do one nutraceutical to be able to help calm down internal inflammation and hopefully boost production, one drop for lubrication, and then one sort of lid hygiene related procedure. Because if we can do something to clean the eyes, to lubricate the eyes, and to help boost production at home, then we're making that a routine for the patient, as well as they're not mixing things up of what to do and when.
I love that. I love that. It's really helpful. Thank you for that. And then, all right, so let's talk. So that's a patient now. And then do you schedule the treatment, the in-office procedures, for example, and the same day? Do you have them back in a week or two? Give us the flow. Now, you're obviously in your specialty clinic. So, just step back for help the optometrists here on the call who are running their practices, running their clinics. They're not in the referral specialty clinic. So what should they be doing? Should they be handing it off to their dry eye coordinator so that they can close and sign them up or schedule them? And then do you talk payment at all? Let's just walk through a little bit of that before we get into treatment.
Sure. And so it kind of depends on the office setup, right? And not every office is the same. Some people are doing this as solo practitioners with maybe one other employee in the office. Some people are doing this with multiple lanes, multiple tech rooms, and you have a dry eye coordinator that also was maybe your surgical scheduler in an ODMD setting. There's lots of different mixes that can be done there. And it's hard to be able to say exactly what to do in each situation that way, because chair time is a thing. How much time you're going to be able to spend with each patient is very indicative of how successful the treatment protocol is going to be. So in our practice, we've kind of experimented multiple ways. We have done treatments on the same day. We've come back for treatments depending on if we have the time and the availability. It's actually how we got my dry eye clinic started. Was we were doing too many procedures on the same day that my opticians were starting to get pissed. I'll be honest with you. I was starting to, because we were bonusing them on glasses and contact lens sales, and they weren't selling those products because I was doing dry eye services. Right. So if I didn't move the clinic out and make my own referral clinic, they were going to string me up. Right. So it was one of those things that we have to get there.
No, it's a very important point. I mean, this is a very important point. There's a struggle. There's an internal battle going on between the current business to the future you're trying to build. You've raised a very important point.
Yeah. And so when it comes to those conversations too, I take a look at the intensity of the treatment. So for example, let's do a severe case patient that we're having this conversation. We've brought back for the evaluation, right? Where we're done the in-depth talk about, say they have 3+ rosacea blepharitis with, the Demodex component, as well as a little bit of lag ophthalmos and poor meibum expression. Like you're talking one of those kitchen sink kind of cases that you want to throw everything at. Where normally when it comes to MGD, I'm looking at something that is going to, like I said, remove inflammation, remove obstruction, and increase production. So when it comes to removing obstruction, there's two areas that are truly can be obstructable. One is the gland surface, right? We can have the orifice, the opening. And then the second is actually intraglandular. And so we want to make sure that we're targeting both of those areas when we're coming to the treatment. So to start off with the treatments, I want to at least make sure we get the orifices open, right? Let's clear off the caps. Let's make sure there's no biofilm present. Allow that if there is good oil in those glands, that there is going to be having the possibility to come out. Yeah. Likely in those inflammatory cases, we're going to need to implement then some anti-inflammatory treatment as well, whether it be you going medication-wise, like a doxycycline, regimen, or if you're doing in-office like IPL to be able to help out with that. That's when we start calming the inflammation first. And then towards the end of that protocol is when I do something thermal like LipiFlow to fully flush out the glands. Reason being, and it'll say this even in LipiFlow's own paperwork, that if you have more than grade 2 inflammation on the lid margin, that you may want to be careful and bring down that inflammation first prior to doing the procedure. Reason being is, imagine if you got a bruise, would you go home and put a hot pack on it to make it feel better? Not exactly right? And it's great for the oils, it's great for gland expansion, but by adding heat too much too quickly, we could be exacerbating the long-term inflammation. So there's got to be a right time and a right place for you to be able to implement that treatment to have it be the most effective for you. And so as we've kind of put it towards a little bit later on in the protocol, we've been having better success, and then extending the life of that treatment more for the patient, that they don't have to come back as quickly for it, and they can get, want to do it when they know it's time is necessary.
Yeah, no, I like that, because a couple of different things. One is that you really are speaking a medical language, which is inflammation, the root cause of so many problems that we have today. And then you're saying, well, we're going to try this and we're going to try this. And so let's make sure that we do this stepwise approach, because what I'm hearing as a patient is being thoughtful about customizing a plan for me. It's not like, hey, I think, this particular instrument is going to solve your problem. There's none of that. It's really, hey, we're going to try this. We're going to try this. I recommend the following because of the following reasons. And let's go with that, and then see how you progress. And then we'll get you down the journey of doing the LipiFlow. So I really appreciate that. The other thing is, it's not sounding as salesy either, right? It's sort of like, hey, I'm a doctor. And I love, by the way, Dr. Beck, I don't know if anybody see this. He's wearing a white coat, folks. And you know how I feel about white coats. So I love that in the white coat. But this is what doctors do, right? They, you're diagnosing conditions, and you're actually leading the patient down a journey of treatment. So not just saying, okay, I've got this one thing, it's magically going to solve your problem for, X amount of money. And so I think it's really important for that. So now, thank you for that. Thank you for leading us down this patient pathway. Let's switch gears. Let's move to the second level now. Let's talk about doctors, optometrists. What are some of the things that you think, I wish I knew this earlier in my career? And, these are two things I wish I knew earlier. I would have been so much more accelerating, faster acceleration of my dry eye clinic. So tell us a couple of those pieces of advice.
Sure. So we were a practice that stumbled when we first got started, because we saw all this wonderful information, but we didn't know how to implement. And so I'll be honest with you, we were a practice that bought a LipiFlow back in 2017, 2018, and it sat in a corner for about 3 months until we figured out exactly how we wanted to utilize it and get it up to speed. And we were starting to feel the burn. The payments are starting to come through, and we really needed to start utilizing it and getting up to speed. And I keep going back to imaging. Imaging was key for us to be able to show the patient the necessary, treatment protocol and what was kind of going to happen if they didn't. And that was one of the things that drove that patient base. So we actually use a lot of the imaging from Johnson & Johnson. They provided us with normal, significant gland loss and severe gland loss photography that we have on demonstration, that I even blew up into poster size in our practice, so that people are starting to take a look and just say, what is that inside the eyelids? I didn't even know those things were in there. And, they start talking about meibomian glands and starting to realize that, hey, this is something I might need to take care of. The second thing, though, for treatment, as far as concerned, was making sure that the treatment is going to be as successful as possible. And I didn't think about this until after I had done a number of LipiFlow treatments, was that we're emptying the glands. And we're emptying the glands. It's great, and then of all this potential bad material that might be stuck in there. But those glands need to refill. And we need to make sure that we are filling those glands up as soon as possible, so that we can restore normal function without having to be reliant on drops or other over-the-counter products that may be. So ideally, while I'm going through my treatment protocol with my patients, is I'm starting them on something to increase production prior to evacuation, whether that be one of the medications like varenicline to be able to stimulate tear production, whether it be an omega-3 vitamin supplement to be able to help wholly boost oil. And I want them on that for 2 to 4 weeks prior to the LipiFlow procedure, so that they have a quicker re-up time after we evacuate the glands. Also included with our LipiFlow procedure is we give an oil-based MGD, preservative-free artificial tear, one small box, to the patient, and tell them to use it once every hour or 2 hours for the next couple of days while they're awake, just to make sure. make sure we're coating with something until we know that the glands reflow, because unfortunately, I don't think the technology is there yet for us to be able to say exactly how quick that is going to recur for most people.
Got it. No, that makes sense. So we've got a question here. I'm just going to put on the screen here for us. Let's see here. So there's the question. For a while, there was a CPT code for LipiFlow that Medicare paid. Is that still the case? And are there any medical insurances that pay for it? The question.
So, from my understanding, that there were a couple different regions that this was being tested. It wasn't every Medicare allowable region at that time. I know that for a while that it was pulled and put through a different consulting company and then maybe reapplied and things like that. But I think they kind of hit a stall. So I'll be honest with you. Please 100% don't quote me on it. I think that there hasn't been a lot of progress in a while on getting the reimbursement at this point. Either way, we do have patients sign ABNs for all of our procedures in our office, that if it isn't coverable by, these medical insurances, that we, obviously require the patient to pay for the procedures. Because although I wish I could do all my procedures for free, I can't really do it.
Yes. No, absolutely. And I think what's really interesting is that you take that step-by-step approach. So they realize that it's one of those things that is important, but not quote unquote pushed up front. Right. It's not like you're saying, look, I'm going to do this. I'm going to do this. So one question, Dr. Beck, I have for you. So a lot of patients say, doc, or do you think a lot of patients get reluctant when they hear the word dry eyes because they think drops are the solution? I'll just go to Walgreens, Dr. Beck, right? That's what they're thinking in their head. They go home, they're like, do we really need to come back for this thing, dry eye follow-up and so on? And so one of the things we coach, our members on is the language you use is an ocular surface evaluation. And so don't talk dry eye disease per se, but talk MGD if you have some diagnosis of it, because that shifts the dialogue from, the pharma companies are sort of constantly thinking about drops and training consumers to think dry eyes equals drops. So what we want to do is to make sure the patient is getting right treatment. So talk to us a little bit about that dialogue that the doctor can have with the patient to talk about inflammation and not just drops.
Yeah. And that's incredibly important. So the way we've structured it in our clinic is it does require chair time initially, especially on that initial evaluation, but that chair time has significant ROI. So for all of our new dry eye evaluation patients, we actually book them for an hour. Which may be unheard of in a lot of different practices who are running on a 15 or 20 minute time schedule. But the reason why we book them for an hour is because we're doing 20 minutes worth of testing when we first get started. For the devices, we have multiple different anterior segment cameras that all have different functions. We have the interferometers and the myobographers, and we also do the tear sampling and testing as well. And then I'm also making sure that I spend at least 20 minutes talking to every patient on their first visit. And that 20-minute time is hard to come by in a medical clinic setting in general. So when you get that one-on-one with the doctor and being able to explain, here's the imagings, here's what I saw, here's what I know about the diagnosis, and what I think is going to be most beneficial for your treatment plan, it goes a long way on the buy-in to be able to get started. And, there's obviously things like cost being a factor. Medical insurances, we will pay for some procedures, but not for other procedures. And we tell our patients all the time, we're going to do our best to be able to make sure that insurance will benefit you as best as possible, but there are some out-of-pocket concerns. Now, you mentioned a good point about over-the-counter products. I hate to give my patients homework. I don't want to send them to CVS, to Walgreens, or things like that. I'd rather them get them from me, here and say, okay, this is the right product for you. And I'm perfectly okay with that and getting started as long as the patient is going to be comfortable and not in a severe disease state. Right. But what I encourage them is to say, if you're going to start out with nutraceuticals, drops, lip wipes, whatever it may be, I want to see you a little bit sooner for the follow-up. Instead of, say, for example, I put them on an immunomodulator that has a 6 to 12 week up ramp time. Well, then I'm not going to expect to see results for 3 months, so I'll schedule you in 3 months. But if I'm seeing maybe a nutraceutical or a drop or a wipe that can take an effect within a couple of weeks, well, in 4 weeks, I'm going to see you back. And in that 4 weeks, if we haven't seen significant progress, now it's time to say, well, we tried the over-the-counter stuff. It really wasn't as effective as we'd hope it would be. I think it's time to start implementing that interventional therapy for you. And then thus the buy-in is a lot easier because, they've already given it the college try at home and they're ready to take that next step.
Yeah, no, I love that. So the next step, let's talk about LipiFlow now. Let's talk about LipiFlow and I think, if you don't mind, just walk us through. So also LipiFlow comes with LipiScan, right? Often. So it's sort of do you use LipiScan as well, or just talk to us about that? Yeah.
So in our offices, we have LipiScan in a number of our satellite offices. I do have one in my office too, but I've used more of the LipiView too. For it's a little bit different technology if some people are familiar with it, as well as we have some other interior side cameras, as I mentioned before. The thing that I really like about the LipiView too has been great was not only does it have the mybography built in, but it does a blink analysis to see if there's a lag ophthalmic component, as well as it does a mybum measurement to see how many nanometers or mybum are you actually producing per blink. And there's a normative range that was come up with by Dr. Korb and this team over at Johnson & Johnson a while back that said we need about 100 nanometers of oil to be able to sufficiently coat the ocular surface. And if we don't have that amount, well, we need to do something about it. But the machine is bigger and it needs the foot space to be able to do it. So a lot of our clinics that just don't have the foot space for it will have the LipiScan in, and at least that's showing the structure to say, yeah, like I talked about before, structure is not great. There should be some sort of dysfunction happening and going from there.
No.
And then the LipiFlow, as we implement it, is again meant to evacuate the glands. And one thing we also make sure we inform the patient is that this is not meant to make those glands go from looking at the dysfunctional structure like you see here today back to that perfect normal structure they had when they were 10 years old. Well, maybe I should say younger now that we're seeing it even earlier, right? But we're trying to do is prevent any further progression. And with our other therapies, hopefully be able to restore some more function than they've had previously.
So LipiFlow, how do you talk about it in a way? Do you educate them about thermal pulsation, about LipiFlow? Do you visuals? Does your staff do it? Use videos, brochures? Like, how do you get into what LipiFlow does and what to expect on the day of the procedure?
Sure. So, I do a brief, I like anytime I introduce a treatment is to do it twice. This is very important. I do a brief explanation in the chair, and then my staff does a second, more detailed and thorough explanation when talking about obviously costs, et cetera, too. So that they're hearing it in multiple different touch points, because the more they hear it, the more it's going to be reinforced of, okay, this is what to expect, this is what's necessary, and how do we be able to go. So in general, I know I talk about LipiFlow on the most superficial terms. I explain it like a spa treatment, that it's a warming massage for the eyelids. And essentially that's what it is. It's a temperature controlled warming device that warms up the mybum to the proper temperature to liquefy it, and then massages your eyes at different pulsations for 12 minutes. And what it does is it massages out all those oils and empties out the glands and resets them as close to baseline as we could possibly be. Once that's all cleared out, then we check and see the function and see how everything is doing. And then not only do we check a little bit right immediately after the procedure's been done, but we'll also schedule a follow-up about 1 month afterwards to see how effective the treatment has been. And so when the patient, they hear about, okay, it sounds like a pretty easy procedure, but not only is it an easy procedure, they're going to follow me and make sure that it actually worked. There's a sense of comfort there. They don't want to just say, oh, yep, just did the procedure and now I'm left off to the masses and hopefully it got better. Yes. No, this is a doctor-patient relationship. We're making sure that we're going to be continuing care with them through the long haul and making sure that's effective.
Yeah, education is the key for signups. I mean, we talk about this all day long, is that what you're doing is really educating the patient to make their own decision about their own, course, their own life, their own eyes. And I think it's really important to educate as much as possible. So I love that. So we have one more question here, Dr. Beck. And then, so here's the question. How do you objectively evaluate LipiFlow treatments at follow-up? Does mybography improve with LipiFlow treatment or just not get worse? Great question from Dr. Reebok. Yeah.
Perfect. No, these are really good questions. So mybography is going to take the longest to change out of any of the different imaging diagnostics that we see. It will take the longest amount of time, whether it's going to get better or worse compared to follow-ups. There's many offices that only do mybography once every year because they know that this process is going to change. So there's other determining factors to judge how efficacious this is. I mentioned the LipiView 2 before. That obviously can tell us the nanometers of how much oil is coming out for blink. But in addition to, the simplest way is doing your fluorescein stain, right? What's your tear breakup time? Has your tear breakup time improved since we had the LipiFlow procedure done? Did it go from 3 seconds to 7 seconds or 10 seconds? And did we show an increase? That's really the big thing. Are we showing an increase in the effectiveness of those oil glands? In addition to, if you do have the anterior segment camera, while you're using that device like the meibomian gland evaluator and doing it under the slit lamp, and you can film potentially, I'm pushing with a normal amount of blink, and now I actually see oil coming out, whereas previously we did not. That restored function right there. And that's a great thing for the patient. One of the things that I do in my electronic medical record system is I do record on every evaluation how many meibomian glands are expressing per visit. And a lot of people will now come in asking, hey doc, what's my number? What's my number of how many you're expressing today? Did it go up? Did it stay the same? I'm like, well, yeah, but you didn't do your lid hygiene for the past month, so it went down 10%, or something along those lines. And they like to have these metrics to be able to help track, because they may be feeling better, but they want to know that it's looking better as well.
I love that. Actually, it's so funny, but I'm in my 50s, and my friends at dinner, we're talking about cholesterol numbers. We're talking about your calcium scores. You're talking about, blood glucose. So it is the name of the game these days, is that people are talking about their metrics and their health numbers, from, steps, how many steps you got in, to how much you ran, to your glands. Who would have?
Gotta be trackable. I know maybe they'll add it to an Apple Watch at some point. I don't know how they're going to track it if we stare into it, but we'll see.
Exactly. All right. So let's wrap up, Dr. Beck. So we're talking with Dr. Beck. We've gone over time, but I just wanted to sort of ask Dr. Beck. Dr. Beck, one last piece of advice for optometrists, for eye doctors who are into dry eye disease management, or just trying to get into dry eyes. What's your advice for them that you'd say, do this one thing and do it really well?
Oh my goodness. I wish. I mean, education is absolutely key. But beyond that, because what education really leads to is trying. And trying as the practitioner to push yourself to be able to say, look, I see this diagnosis. I want to push for that interventional treatment with the patient because I believe they need something to get and to feel better. And even though that jump is scary, just like our first jump into practicing was very scary. But once we start trying it and got more familiar with it, we kind of knew what to expect. How effective was this treatment going to be in each of the different cases? And then as that confidence builds, then you were able to recommend it in the right portion of your protocol. And that success just kind of breeds itself. People start talking about how great it was, and then they start referring their friends over, and then it naturally grows. And I'm sorry if you all have to open up second clinic locations because of it. So.
That's a good problem to have.
Right?
Because, someone snuck a question in, Dr. Beck. I'm sorry. Are you recommending a heat mask as homework post LipiFlow procedure? Sorry about that. Somebody snuck a question.
So that's a really good question. And when it comes to my methodology on heat, heat, like we said before, it's great for liquefaction and gland expansion, but it's terrible for inflammation. So we have to be very careful. And if this is a borderline patient who was a little bit still inflamed, but was okay to do LipiFlow at that point, it might not be the best to continue with an excessive amount of heat at home. So I've adjusted recently to kind of recommending almost once every other day for a heat mask, and not once every night any longer, or twice a day like I used to, just so that we're enough to keep things moving, but not enough to exacerbate the inflammation. And the more that you start working with your patients and judging those at follow-up, the more you're going to get comfortable with how often you're going to want that to reoccur.
Perfect. Great answer. So I'm going to just close it here. There's a number of people who love you, Dr. Beck. You got a fan club going on here. And so I'm going to ask, so we're going to post Dr. Beck's LinkedIn profile so you can get in touch with him anytime you wish. But I just want to say thank you, Dr. Beck. I'm going to close the call here because we've gone over time, and I want to be respectful of everyone's time this evening as well. But we've got a lot of great programs. Check out gethoot.com/events. And if we've done an event, the recording will be there. So the recording of this live stream is going to go live tomorrow on the site on gethoot.com. So check it out. But Dr. Beck, I want to just say thank you so much for sharing your wisdom, your experiences, your advice, your perspectives, your workflow, your protocols, and all of that with us tonight. I learned a lot, certainly. Inflammation, obstruction, production, inflammation. I'm going to go to bed. Inflammation, obstruction. My wife's gonna be like, "What are you talking about?" But, so
the gospel, and that's all I can ask for. So thank you.
But great presentations. We've got some great comments from people here. So if you like what you heard, Follow Dr. Beck on LinkedIn and social. Follow Hoot us. And, Dr. Beck, thank you so much for your time. I really appreciate it. We're going to close. Have a great night. Thank you.
Thank you. Happy to be here and happy to share. Thank you guys. And thanks for everybody for having me.
Thank you, Dr. Beck. Take care.